That's a profound and very timely question. Let's carefully unpack it so you can see the differences in diagnosis and treatment between stress and trauma, and also which age groups are most affected and why in today's society. 1. Defining stress versus trauma. Stress. A natural physiological and psychological response to a challenge, demand, or perceived threat. Can be acute, short-term, e.g. exams, deadlines, or chronic, long-term, e.g. financial strain, caregiving burden. Usually resolves once the stressor is removed. Trauma. An overwhelming experience that shatters one's sense of safety or stability, e.g. abuse, assault, war, severe neglect, disasters. Leaves lasting changes in brain chemistry, body responses, and emotional regulation. Can lead to PTSD, post-traumatic stress disorder, or complex trauma when repeated, prolonged. 2. Differences in diagnosis. Aspect stress trauma. Diagnostic category. Not a clinical disorder itself, but can contribute to conditions, e.g. anxiety disorders, depression, adjustment disorders. Recognized in DSM-5 as PTSD, acute stress disorder, or complex PTSD, ICD-11. Symptoms: irritability, worry, sleep disturbance, muscle tension, headaches, fatigue, intrusive memories, flashbacks, hypervigilance, emotional numbing, avoidance dissociation, assessment tools, stress scales, perceived stress scale, occupational stress surveys. Trauma-specific tools, CAPS-5 for PTSD, Trauma History Questionnaire, ACEs scale. 3. Differences in treatment, stress management, lifestyle interventions, exercise, sleep hygiene, time management, mindfulness and relaxation, meditation, breathing exercises, counseling CBT, reframing thought patterns, problem solving. Medication, occasionally short-term, e.g. for anxiety or insomnia, trauma treatment, specialized therapies, EMDR, eye movement, desensitization and reprocessing, trauma-focused CBT, somatic experiencing, body-based therapies, pharmacological support, SSRIs, anxiolytics, mood stabilizers in some cases, group, community therapy, especially for war survivors, refugees, disaster victims, longer-term process, rebuilding safety, trust, identity. 4. Age groups most affected today. Children and adolescents, more vulnerable to trauma, abuse, neglect, bullying, family violence. Their brains are still developing. Higher risk of long-term effects, anxiety, attachment issues, learning difficulties. Why? Because adverse childhood experiences, ACEs, shape the nervous system and stress response pathways for life. Young adults, 18-30, high stress rates, academic pressure, job insecurity, social media comparison, financial instability. Trauma risk tied to sexual assault, domestic violence, or accidents. Why? Transitional phase of life, often lacking stable coping structures. Middle-aged adults, 30-55. Chronic stress from work, caregiving for children or aging parents. Trauma more often linked to sudden life events, divorce, serious illness, loss. Older adults, 60+, stress often tied to health decline, loneliness, financial insecurity. Trauma may resurface, e.g. war memories, unresolved childhood abuse. Why? Reduced support networks, cumulative burden of loss. 5. Key takeaway. Stress is widespread, short-term manageable, and often normalized in society. Trauma is deeper, less visible, and more stigmatized, requiring specialized treatment. Most affected. Today, stress, young adults, due to modern pressures, economy, jobs, digital culture. Trauma. Children and adolescents, because early trauma rewires development with long-term consequences.